Thank you, Todd. And it certainly is a pleasure and an honor to introduce our next speaker, Dr. Linda Worrall. And certainly this is somebody who needs no introduction. It's really just truth to say that every single person who's attended this teach-in or has presented this teach-in or been part of Aphasia Access has really been influenced by you, Linda. And we could talk about, I looked up more than 200 articles that you have, 6 books, dozens of PhD students. We just wouldn't have the time to talk about all of that. However, in addition to your tremendous influence on all of us, we did want to mention how meaningful and impacting among all the work you've done, your recent work on the 7 habits for effective aphasia services and how you emphasize the importance first and foremost on prioritizing the relationship. So certainly without any further ado, we want to thank you for being part of this, Linda, for being part of the teach-in, for all of your work in Australia and throughout the world. It is just a tremendous honor to have you presenting here. And with that being said, I'll turn the Zoom over to you. Thank you.
Thank you so much, Tom. I really appreciate you staying up and introducing me. Can everyone hear me okay? Todd, it's coming through okay?
Coming through lovely. Hear your voice and see your slides.
Lovely. So, good afternoon from Brisbane, Australia. And I thought I would take a topical title to this presentation and call it Ban the Flattening Curve, mainly because over the recent sort of times, we have heard a lot about curves. And so here we go. So is it moving on now, Todd?
Yes, it is. And,
it moved on. Thank you. Just checking.
Nope.
So we've all seen this flattening the curve during the COVID-19 pandemic, and I think we're all pretty much fed up with the curve. But it made me think about the curve that we use in our aphasia rehabilitation. So I asked people on Twitter, I said, do you still use, the flattening recovery curve to explain prognosis with people with aphasia? And everybody said, well, yes, we do. It seems that a lot of speech pathologists will still hand draw the recovery curve in relation to when a patient or their family member asks, will I get better? So I thought that I would like to discuss how this recovery curve, the impacts that it has on people with aphasia and their family members particularly. So which recovery curve do you use? I think a lot of us have adapted the straight recovery curve, and here's some just from Google Images. And some people use a bit of a step-by-step sort of type of analogy. Some people talk about different sort of recovery trajectories, and some of these curves are in relation to different phases of the recovery process. And so I know that therapists will use some of these varieties of the stroke recovery curve when they are talking to their clients about recovery. So what I'd like to talk about is, first of all, Bonnie Chang is doing her PhD on this process of prognostication, and she surveyed 54 speech pathologists And as part of that survey, she asked about their level of agreement about whether they were asked to provide a prognosis, and there was a very high agreement that they are still asked to provide a prognosis. The survey also found that there was 87% agreement that it was emotionally challenging to provide a prognosis, 80% agreement that it was intellectually demanding, 73% agreement that they know what factors influence prognosis. That is, that they know the research, they know what factors influence prognosis. So a 73% agreement there, sort of suggesting that they were fairly confident. But there was 100% agreement that they had changed their practice with more experience. And certainly when I think back to the recovery curves that I used as a beginning clinician, I have certainly changed the curves I use to explain prognosis. So, and I'm sure we're all in the same boat. So the overarching aim of this presentation, which is clearly a difficult conversation, a difficult clinical practice that we do, it's to help aphasia therapists begin with the end in mind by rethinking the use of the recovery curve in prognostication conversations with people living with aphasia. So what I thought I would do is to deconstruct the aphasia recovery curve, then to showcase some of our research that challenges some of the assumptions in that typical recovery curve, and then to begin to reconstruct the aphasia recovery curve. Why? Well, I think I have, and I'm sure everybody has heard someone with aphasia or their family members say that the doctors told me that I would never get better, I'd never walk, I'd never talk again, that I would, you know, sort of that there would be very little progress after I left hospital, all of those sort of things. And so we still have a situation where too many people with aphasia talk about the negative effects of this discussion with health professionals. So there are negative effects of this prognostic discussion. So I'd like to see if we could change that. The second thing is that it seems to be limiting everyone's scope of recovery, and particularly service provision. And I'll explain that sort of limit on service provision in a minute. And thirdly, I think that old recovery curve really does not represent modern day concepts of rehabilitation and evidence-based practices now. So let's begin by asking, well, is the recovery curve a problem? So I do think that there is a problem. If this is your typical sort of type of recovery curve there, I think some of the messages that it sends to people living with aphasia are that, well, on the positive side, it says, well, yes, there is recovery. There is that curve actually goes upwards. Another positive message is that most recovery occurs early post-stroke, so that what you're going to see is a very sort of some rapid recovery, so you're not going to be like you are now. And this is assuming that this prognostication discussion is going on fairly early in their stroke journey. But on the other hand, I think there is some negative messages that recovery slows down after a few months, and that's the flattening of the curve. I think it also suggests that perhaps recovery stops after that, or that we don't know what recovery is going to happen after that. It's also maybe that there is a suggestion that there is a limit to how much recovery can take place, because that curve, that line, doesn't go right up to the top. There's also a suggestion with restricting, if we just restrict that sort of timeline to the first few months or even the first year, that recovery, most recovery takes place here in hospital or in hospital, so that there's not much sort of suggestion or discussion about what happens after hospital. Also, that it sort of implies that only rehabilitation helps recovery. That is, that when you're in hospital, you're getting rehabilitation, and that this is how the recovery curve that results as a result of our rehabilitation efforts. However, on the sort of positive side, I think a lot of people will talk about that this curve, it may not be a smooth curve, it may sort of go up and down. And some people also talk about how people do recover at different rates. And so they maybe sort of temper the sort of flattening of the curve, if you like, by saying there's a lot of individual variation. Recently, there has been a stroke recovery model that has been developed through a consensus process from the Stroke Recovery and Rehabilitation Roundtable Task Force. And so you might think, well, this should be the most recent recovery curve that encompasses all the most recent sort of research, and it's the a consensus by a lot of leading stroke rehabilitation leaders. But I don't know about you, but first of all, I don't think it's very aphasia friendly in that there's a lot of emphasis, there's a lot of big words in here that on the positive side, it does, the arrow at the end along the x-axis suggests that recovery continues past 6 months post-onset. And it also suggests that there is improving impairment and functioning with that orange line. But it does go into a fair amount of detail of why there is recovery, and it's, you know, through endogenous plasticity, inflammation and scarring and things like that. And there's a lot of emphasis on this early phase. So even though that's been around for a couple of years, we haven't really translated that into an aphasia-friendly model. The aphasia-friendly support material that is available is from Kathy Can in the UK, who's developed an aphasia-friendly version of prognosis. And in this, she talks about recovery from stroke taking a lot of small steps, that it takes time to recover from stroke, and that in the first weeks changes may be rapid, but that smaller changes can be experienced years after the stroke. It's simple, and perhaps it does encapsulate some of the more recent sort of thinking in this area, but I think we can improve on it. Tactus therapy use an actual photo image, and this really is probably more in relation to trying to debunk the plateau myth. And Megan Sutton from Tactus Therapy uses a photo of a plateau and talks about that beyond the plateau is focused, effortful progress. And so that's another sort of aphasia-friendly sort of analogy, if you like, that can be used. But of course, we always need to tell the truth if we can. And let's have a look to see if this recovery curve is actually true. So these are all sort of graphs that again are still from the aphasia literature, and you can see that most of these graphs are, first of all, short term, and secondly, they all show an upward trajectory. But these recovery curve assumptions, I want to sort of tackle these ones. That when we talk about aphasia recovery and outcomes, that we talk about language recovery and outcomes. And I don't think that's the way that speech pathologists really think, or that people living with aphasia think. I think they talk about recovery in broader terms than just language. Secondly, I think that one of the assumptions, if you just use one curve, is that everyone recovers the same way. And thirdly, that I want to tackle this idea that rehabilitation and recovery only happens in hospital in the first few months. Now, how I'm going to do that is, first of all, to talk about some of our research on outcomes, and then our research on trajectories, and then talk about long-term support needs. So, unsurprisingly, our research on outcomes has talked about sort of what people think are the outcomes. And this survey that Bonnie Cheng did about prognostication tells us, though, that speech pathologists still use the word language to describe the outcome. They are not talking about broader outcomes when they're drawing their recovery curve. But during prognostication, when they're thinking about what am I going to tell the person with aphasia about recovery, they take motivation and the amount of social support into account, as well as the nature and severity of the post-stroke deficits. They also modify their story based on the patient's comprehension, emotional health, and hope and expectations. So even though they are talking about language as the outcome, they are thinking about the much bigger picture when they're talking to the person. They're talking about non-language factors when they are thinking about prognostication. So it's a bit of a mixed message that speech pathologists are giving. So let's move to the research that we've done on outcomes and trying to identify what outcomes are meaningful for the different stakeholders. So first of all, speech pathologists. What do speech pathologists think are the outcomes of aphasia rehabilitation? And this research was formed part of Sarah Wallace's PhD. And she did an eDelphi consensus study to find out what treatment outcomes are most important to aphasia clinicians and managers. What she found was that, in fact, dyadic communication between the person with aphasia and their communication partner, that was the most important outcome that speech pathologists thought should be the result of aphasia rehabilitation. The second prioritised outcome was psychosocial wellbeing, and the third one was communication partner knowledge and understanding. So in there, even the speech pathologists are saying that outcomes are broader than language. They are saying that things like dyadic communication and psychosocial wellbeing are the most important outcomes. In terms of what people living with aphasia think are the outcomes, again, it's one of Sarah Wallace's PhD projects. And what she found through a international nominal group technique study was that, yes, people living with aphasia thought improved communication was the primary outcome that they were looking for. They described communication in usually much broader terms than we talk about language. They talked about communication for talking with their family, or communication for talking with friends or on the phone. So their concept of communication was very much more at that sort of activity level. They also prioritised increased life participation, but interestingly, they also said that changed attitudes through increased awareness of aphasia should be a priority of aphasia rehabilitation. They also talked about recovered normality, improved physical and emotional well-being, as well as improved health services. So this project, which Sarah, we've called the ROMA project, Research Outcome Measures in Aphasia, shows very clearly that the outcomes that the primary stakeholders want, it's more than language. So in the ROMA project, which has chosen some key assessments for research purposes, she's developed the core outcome set for aphasia effectiveness research, and for language, the Western Aphasia Battery revised has been chosen. The psychological wellbeing is the GHQ-12, the SACWOL 39 for quality of life, and the scenario test for communication. And this core outcome set was decided through a very extensive consensus process by an international group of leading researchers, and it's an ongoing project. But the message that I want to give from that is that worldwide, through all of the different stakeholders, outcomes are more than language. So the first take-home message when we're drawing that recovery curve is to include broader outcomes than language. So I'm not a very good artist, but it is a matter of putting another line, at least another line, on that sort of recovery curve. And a potential script that you might use to convey this information might be something like, recovery of language is quick in the early weeks, But recovery from aphasia is not just about recovering your language skills. It's also about how well you use your language in everyday life. We expect that you will be able to communicate in everyday life better than you can talk, and this will get better over time. So that's the first take-home message. The second part of this talk is about our research on trajectories. We followed 26 people with aphasia over 12 months, and we assessed them on the assessment for living with aphasia at 3 months, 6 months, 9 months, and 12 months. So most of the recovery curves in the past have used, for example, the WAB aphasia tests. And this is, the assessment for living with aphasia has two features that I think are pertinent to this discussion. First of all, it is a more generic global measure of quality of life. And secondly, it is self-report. So the self-report sort of feature of it, I think, is important when you're talking about prognosis, because ultimately it's what the person with aphasia and their family members think is happening in recovery, rather than what is shown on a test like an AQ. So this sort of self-report process gives us an idea of what they're thinking, how their impairment, activity, participation and things like that are going over time. The majority of people had this upward trajectory, and that's what you would expect in the first year. There were 2 people who had a fairly unchanging, steady, unchanging trajectory, but they were sort of reaching ceiling anyhow, so they were fairly mild. There were quite a few people who had a fluctuating, what we called an up and down fluctuating trajectory, a bit all over the place. And to some extent there were episodes, sometimes that was due to episodes that had happened in their life, or you know, they'd gone home from hospital, or they'd gone back to driving, or whatever it was. So their perceptions of their communication and communicative quality of life were perhaps changed as a result of that. The final sort of trajectory was a downward trajectory. And this was, there were 3 cases there. And again, there were multiple reasons for that downward trajectory. But I think the point that we want to make with this data is that not everyone has that typical recovery curve, and that we need to think about how we can prevent this, particularly this downward trajectory. When we did some very sophisticated structural equation modelling with this data and many other variables, we were looking for what were the determinants of successfully living with aphasia. So we sort of said, well, the outcome that we're interested in is successfully living with aphasia at 3, 6, 9 and 12 months post-stroke. What we found was, and this was, I think, some in the 50 sort of people with aphasia, what we found was that there were positive factors and there were negative factors. In terms of the positive factors, higher household income, contributed to successfully living with aphasia, a larger social network, being female, rating yourself as successfully living with aphasia, which sort of reflected probably more of a positive attitude, and also, of course, having less severe aphasia. And I've put an asterisk against those factors that are potentially modifiable and perhaps that we have a role to play in. So the other sort of on the negative side though, what we found was that higher education, interestingly, was a negative factor, a negative determinant of successfully living with aphasia in that first year, possibly because those people had professional roles at work, had higher language needs, and therefore sort of suffered the loss of this sort of language more acutely. Low mood was another negative factor, as well as poorer physical functioning. But interestingly, this is where the penny dropped for me, in that this low mood had come up in a number of studies that we'd done over the years. And so it sort of made me think that we really haven't been paying enough attention to low mood, and because that it obviously is having an effect on recovery. So the sort of take-home message, the second take-home message, is to discuss possible trajectories. And even though my animation skills aren't great for this, but I would suggest that you could, with your pen, that you can draw different trajectories. With a script of, most people report that they steadily improve, but recovery can fluctuate too. A very common problem that occurs in the first year is depression and isolation. It is very important that you do everything you can to prevent these. And so using those sort of downward pressure ones there to talk about the possibility that depression and isolation are negative factors that are going to have an impact on their recovery. The next part of the talk is about long-term support needs. And I'm going to be sort of observing some things from the third sector, which is in America usually called the not-for-profit. And I'm doing this as with my hat on as chair of the Australian Aphasia Association. So aphasia rehabilitation is very front-end loaded, I think, in most countries. It's where most of the speech pathologists have a role in that sort of very early rehabilitation post-stroke while they're in hospital. And so when it comes to later on in the recovery, there is not as many services to deal with their sort of recovery. The second observation is that transition from hospital to the community can be quite problematic. In our association, we find that people struggle to find us sometimes. It has to be usually the family members who will go onto the internet and find the support organisation. And we have recently developed the leaving checklist for people with aphasia. So that was developed in response to what was coming through from speech pathologists, that people with aphasia were being discharged quickly from hospital because to make way for COVID patients. So, and in that leaving checklist is a lot of things about making sure that they're ready for life in the community. Also, our observation is that that the post-hospital support, it's a lottery. Really, some people seem to find support, whether it's the aphasia, local aphasia group, or whether it's a tele rehab option, but they seem to struggle to find post-hospital support. And that's why we're saying it's very important that the speech pathologists in the hospital give them signposts to find that information. We need speech pathologist support to help people with aphasia and their families find the support they need post-hospital. So the third take-home message is lengthen the time of recovery. So stretch out that x-axis away from just the first few months. Two, I've seen sort of people still recovering years after aphasia. So the script might be something like, your language and everyday communication will keep getting better over time. People report that they continue to improve over many years. We don't have much information beyond about the first year about what recovery looks like and what has an impact on that recovery. And certainly when you've got a chronic condition like aphasia, you would think that we would have that information, but we don't. The fourth take-home message, I think, is when you're discussing prognosis, is to talk about the available services that will help. We often will get people who just think speech therapy, one-to-one traditional aphasia therapy is the only sort of type of service that is available. Whereas we know that intensive aphasia therapy, aphasia groups, computer therapy, ICAPs, teletherapy, and aphasia associations all provide very important, meaningful contributions to help that recovery curve stay up and continue to rise. So the script might be something like, after hospital, there are services that can help you with your recovery. You can access these at any time. People say that it is very easy to become isolated and depressed at any time after aphasia. So it's always important to prevent these. So that may depend upon whether you're talking about the whole sort of type of curve there. So here's the final post-COVID aphasia recovery curve. I would hope that some speech pathologists might start to use this type of more complex curve to prevent people from thinking that there is a lack of recovery after that initial period, or that there's a flattening of the curve. And so what I think is important is that really, yes, we need to balance honesty and hope, but let's make sure that the honesty is what we know. It's evidence-based, and we do have a lot of evidence to say that outcomes are broader than language, that that recovery extends over a long time, that there are different trajectories, and that there are many services that can help people, and so that we give them this sense of hope for the next, for their recovery. So I hope that you have some discussion points about that, because I'm hoping that some people will maybe disagree with some of those points, or maybe I'm preaching to the converted, and that you're all doing this type of spontaneous recovery curve conversation anyhow. So thank you very much, and I'm happy to take some questions. Todd?
Thank you, Linda. Thank you so much. I think that you've given a lot of people things, you've given us all things to think about and whatnot. If you have a question for Linda, we do have the chat feature going. We'd love to hear from you. I'm just trying to scroll. Just as typical, there's some wonderful comments. Amazing work, Linda. Thank you. Linda has put together a fantastic presentation, so relevant to all of us. I will be sharing this information with our SLPs. One question, what do the lines and numbers on the right side of your chart stand for?
Nothing. That was my PowerPoint skills with an Excel chart. So the numbers were not meant to mean anything. They were just random numbers.
Wonderful, wonderful, wonderful. Any other questions? Linda, we're doing a little bit of reminiscing and thinking and just celebrating where we've come from and where we are today. So I'll ask you a question of, you know, of all the trips, all the community that you're a part of, the collaboration and all that, is there a memory, whether it's in Australia or on one of your trips to Aphasia, or something that just stands out as a smile as we sit here at a very early hour in your day and a very late hour in our day?
Oh, so you want to sort of, you're asking me to pull a memory from one of my trips. I was listening in to the interview with Audrey, and I think I first visited Audrey Holland in 1985 and was looked at her her new test, the CADL or the CADL in America, and that was sort of exciting. But then I went back as part of a sabbatical and spent quite a bit of time with her, and it was there, I think, that she convinced me that I had to start a consumer organisation, the Australian Aphasia Association. So I'm still there, still doing it, and it, I think, speaks to Audrey's wisdom in that if we do not have a strong consumer base advocating for aphasia services, then we're not going to get anywhere. Speech pathologists advocating for more aphasia services is just what's the word? It's promoting our own profession and more services, that self-serving, that's what the word I was after. So I have a strong belief in a strong consumer organisation, and I think Audrey put that in me.
I think Audrey's got, we all have a bunch of those stories of a conversation with Audrey, it sure as heck seems. Yeah. I know that one of my favorite stories was Asha in Orlando, and if you were there, you know this. We Aphasia Access decided to celebrate and have a bit of a lunch and an open-ended conversation. And by coincidence, I happened to sit next to Linda. And I slipped her a note in the middle of it and said, hey, can you talk about some things going on in Australia and maybe take some questions? And you were very kind to play along. And it turned into such a wonderful conversation that, you know, I think that might have been the first time you and I talked about this idea.
Yes, I think you mentioned it a few times, Todd. Yeah.
Well, we're just grateful, and thank you, Linda, for being here, not just for this hour, but for, you know, I know you've been on and off, and you've been quite supportive of this event, and we couldn't have done it without you and all the folks down in Australia. So I'll pause and thank all of you right now.
Lovely. Thank you very much, Todd.